Assalamu alaikum. Welcome to PSA online lecture series on cardiothoracic anesthesia. My name is Dr. Saad from Khan University Hospital. So today's marks the fourth lecture of this series, and the topic for today's presentation is risk of major adverse cardiac events in different surgeries and their outcomes. So it's an honor to me to welcome our speaker, Dr. Sheharyar Ashraf, from the Lady Reading Hospital, Peshawar. He's an assistant professor and consultant anesthesiologist and intensivist, and he's the vice president of Pakistan Society of Anesthesiologists, Center and General Secretary of PSA KP. He's also a lifetime member or the Asian Society of Pediatric Anesthesiologists. So we are grateful for him for joining us today and sharing his expertise. So before starting, there are some general instructions for the participants. So please keep your microphones get muted and switch off your videos during the lecture. And if you have any questions, you can post it in the chat box either during the lecture or at the end. And please fill out the feedback form at the end so that you can get the e-certificate. Over to you, Dr. Sheharyar.
Thank you, sir. Thank you for the kind introduction. Are you able to watch the slides?
Yes, sir. You can continue,
okay.
Sir.
Okay, thank you. Good evening to everyone, and thanks for joining us. Today I will discuss the perioperative risk of major adverse cardiac events, commonly called MACE, across different types of surgeries and how these events impact patient outcomes. This topic is particularly important for anesthesiologists, intensivists, surgeons, and perioperative physicians because cardiac complications remain a leading cause of post-operative mortality. MACE is common and clinically significant. Over 30 million surgeries are performed worldwide annually. Around 1 to 5% experience perioperative cardiac complications. Though the percentage seems small, the absolute burden is enormous. MACE increases ICU admissions, hospital stay, eventually cost, and ultimately the mortality. Many perioperative MIs are silent and detected only by troponin rise. So even minor troponin elevations are prognostically significant. To understand this better, we must define what MACE includes. So the clear definitions improve recognition. The MACE typically includes myocardial infarction, cardiac arrest, acute heart failure, significant arrhythmias, cardiovascular death, usually considered within 30 days of surgery. Perioperative MI is often supply-demand mismatch rather than plaque rupture. Many patients are asymptomatic due to analgesia and sedation. The silent MI in post-operative patients is more common than symptomatic MI. So how we do reduce this mortality and morbidity? Definitely the risk reduction begins before surgery. So we have to focus on major three fields: the patient risk, the surgical risk, and the cardiac factors. So we should aim for proper pre-operative evaluation, optimization of comorbidities, appropriate surgical timing, hemodynamic stability intraoperatively, post-operative monitoring and surveillance. Identify high-risk patients early. Multidisciplinary approach improves patient outcomes. Prevention starts in the preoperative clinic, not in the ICUs. So the surgical risk classification is not all surgery carries the equal cardiac risk. The surgical risk categories are divided into three: the low risk, that is less than 1% carries less than 1% mortality. It includes the superficial minor procedures. The intermediate category carries the risk of mortality 1 to 5%. It includes intraperitoneal, orthopedic, head and neck surgeries. And the one that is the high risk includes the major surgeries, and risk is more than 5%. The major vascular, aortic, prolonged emergency surgeries. The surgical stress response increases catecholamines, inflammation, hypercoagulability. So the greater the physiological stress, the higher the cardiac demand. Procedure-related risks further adds to the patient-related risk and ultimately leading to death if not timely intervened. The predictors of the MACE, the patient factors matter more than the procedure alone. In the patient related predictors, heart failure, diabetes, chronic kidney disease, poor functional capacity, and in the surgery related predictors, the emergency surgeries, major blood loss, prolonged operative time, significant fluid shifts. So the functional capacity is one of the strongest predictors of the outcomes. For the risk stratification tools, always it is preferred to use structured tools but apply clinical judgment. The common tools we are using commonly are Revised Cardiac Risk Index, National Surgical Quality Improvement Project. These tools help guide further testing and monitoring decisions, but they complement, not replace, clinical assessment. The Goldman is the multifactorial index used for the patients. It includes certain conditions that carries the points. So the myocardial infarction, it carries 10 points. Age more than 70 years carries 5 points. Gallop or jugular venous distension carry 11 points. Important aortic valve stenosis carries 3 points. More than 5 premature ventricular contractions per minute carries 7 points. Poor general medical status carries 3 points. Intraperitoneal, intrathoracic or aortic operations carries 3 points, and emergency operation carries 4 points. So any patient who got points between 0 to 5 is labeled as class 1. It carries a life-threatening complications ratio of 0.7% and overall cardiac deaths 0.2%. If a patient is scored in between 6 to 12, so it's classified as class 2, carries the threatening complications, life-threatening complications 5%, and overall cardiac deaths 2%. If a patient categorized in between 13 to 25, so it has overall mortality death of 2%, and a patient who is categorized is more than 26 points, so he or she should have a cardiac death percentage is 56%. One of another, the modified Lee risk, the revised cardiac risk index score. It also includes the certain conditions that each carries 1 point. The clinical parameters are prior transient ischemic attack or CVA carries 1 point. Diabetes mellitus requiring insulin therapy carries 1 point. Serum creatinine more than 2 mg per deciliter carries 1 point. History of coronary artery disease carries 1 point. High-risk surgery includes chest, abdominal, or suprainguinal vascular surgeries also include 1 point. So, if a patient who is marked with 0 to 1 is having a low risk, and while a patient having a 2 or 3 parameters, risk as moderate, and any patient who is marked with 3 points or more than 3 having a high risk of mortality, morbidity, or MACE perioperatively. In the patient factors, one of another important is the functional capacity and frailty scoring. We calculate it on the basis of the METs. So anyone who is able to reading, watching television, eating, getting dressed carries 1 METs, and a patient who is able to walk on the level ground with 3 to 4 kilometers per hour are able to do light housework carries 2 to 3 MET scoring, and anyone who is climbing a few stairs, walking on level ground, 6 kilometers per hour, able to running are able to do heavy household activities carries 4 to 9 marks, and anybody who is able to do highly strenuous sports like cycling, swimming carries more than 10 points. So roughly we label them if a MET score is more than 10, so we label them as an excellent functional capacity. For 7 to 10, we label them as a good functional capacity. 4 to 6 as a moderate, and less than 4 METs, we label them as a poor. So the poor functional capacity is also a predictor for the MACE perioperatively. Apart from these surgical and patient-related risk certifications, another certification is on the basis of biomarkers. So any patient who comes to you with an age more than 65 years or age in between 45 to 64 years with significant cardiovascular disease are having a revised cardiac risk index scoring of more than 1. So we need to do BNP or pro-BNP in these patients to stratify them. And also a patient who is known CVD or age more than 65 or age 45 with the symptoms suggestive of cardiac vascular disease undergoing elevated risk of non-cardiac surgery. So we should do cardiac troponins in these patients also. And apart from these, normally we do not recommend the echocardiography, but the patients who is having advanced age or having any symptomatic histories, so we should prefer to do echocardiography for these patients to stratify the MACE predictor in these patients. So the outcomes for the perioperative MACE significantly worsens short and long-term survival. Perioperative MI mortality 15 to 20%, it increases 15 to 25%. It increased ICU stay and mechanical ventilation. Higher risk of multi-organ dysfunction. Overall increased 1-year mortality even after minor troponin elevations. The perioperative MACE is not just a 30-day issue, it affects long-term survival. So the prevention strategies is multidisciplinary, and it starts from preoperative to intra and postoperative period. In the pre-operative period, we should need to optimize BP, diabetes, anemia, continue beta blockers if already prescribed, but not to ones who are prescribed just before 24 or 48 hours. Statins should be continued in these patients, and particularly in the vascular patients who are going for the vascular surgeries. Evaluate need for further cardiac testing based on history, examination, and certain other factors. Intraoperatively, to prevent the MACE, we need to avoid hypotension, maintain oxygenation, control tachycardia, always keep the normal sinus rhythm, and careful fluid balance is the key to manage these patients. In the post-operative period, adequate analgesia, monitor high-risk patients in ICU and HDU, troponin surveillance when indicated are the key to success. And early mobilization is always important for each and every patient. And stability in the perioperative period prevents catastrophic events. So definitely you should evaluate your patients if there is any alarming sign in them in the preoperative, in the pre-op period, rather than to get them in the any life-threatening events intraoperatively or postoperatively. So the take-home message is MACE remains a major contributor to perioperative mortality. Risk depends on patient plus surgery. Structured assessment reduces complications. Perioperative medicine is about anticipating risk before it becomes reality. Thank you.
Thank you so much, Dr. Sharyar, for delivering an excellent lecture for the regarding the perioperative risk for the major adverse cardiac event, as it influenced by both. If I'm not wrong, it's influenced by both the patient physiology and the nature of surgical procedure.
Definitely.
So, any questions from the participants? You can share it in the chat box. So, or any comments you can to share? Any comments? Anyone? So, the perioperative, I think, cardiac risk are the predictable, and these are modifiable, and it can be managed when the physiology and the stress of the surgery are jointly considered. So, anyone, if they want to add something or any comments or any questions. So, Dr. Sharyar, I think there are no more there are no questions. So,
Yeah, definitely. I think
yes.
only two possibilities: either they mastered it, or otherwise they get nothing.
Yes, Dr. Sadia, we can't hear you.
Dr. Sadia. Hello.
Yes.
Can you hear me?
Yes, please.
Okay. Thank you very much. It was really informative. And sorry, I missed just one or two slides of yours in the beginning. But really, it was very captivating till the end. I just wanted to ask if you could mention more about some of the surgeries and your experience that you have experience in your practice during different procedures in general anesthesia.
Okay, thank you, Dr. Sadia. Actually, always the percentage or the risk stratification for patients who are undergoing general anesthesia is, of course, in non-cardiac surgeries. Definitely, patients are usually come with the cardiac conditions. Likewise, they have cardiovascular disease, or they have a previously MIs or previously transient ischemic attacks. So, whenever and with advanced age, whenever these patients are going for any surgeries like a superficial that carries the low risk, like any breast surgery or any local anesthesia surgeries. So they carry less risk stratification. And compared to the intermediate, like the surgeries, the abdominal and the other laparoscopies, and the one then it is the high risk pool that contains more than 5% mortality, and they are about the patients who are presenting for major aortic or thoracic surgeries. So these patients carries the high risk, and based on their prior history and their examination and their lab values, we have to definitely devise a plan for them to avoid or to get the complications in the middle of the surgeries. So what we need is to just incorporate the proper pre-op settings, the proper lab testings, and proper plan devising before starting the anesthesia. And for any patient who has these symptoms, like we explained, in the form of, if it is a high risk surgery, involves the major hemodynamic shifts, or if a patient who has a prior diabetes, TIA, or serum creatinine above than the normal. So these all should go for advanced testings, like from the basic one, the ECG, the echocardiography, and if these patients have poor exercise tolerance testing, then would definitely need CPET testing for them. So, in order to evaluate and give a full plan to the patient and their families, because if we go further proceed with such patient with such conditions and with such surgeries, so this level of risk is involved, either 20%, 50%, or more than 50%. So by categorizing and by risk stratification, we can devise a good anesthesia or a good setup for our patients.
Thank you,
We
Dr.
have a
Sheharyar.
question, Dr. Saad. Can you
Yeah.
take them?
Yes, we have a question from Dr. Hadika. Dr. Sharia, there is one question like, is there any scoring system which we can use in non-cardiac surgery? This question has been asked in the chat box from the Dr. Hadika.
Definitely, as I mentioned, there is one risk stratification tool based on the type of surgeries, the low risk, the intermediate, and the high risk. And the other one is Goldman, and then there is a Lee, and then there is a revised cardiac risk index. So all these, any one of them, we can follow them to stratify the risk of perioperative major adverse cardiac events in our patient. So by following any of these, we can predict the perioperative major cardiac events.
Sir, there is any other question like, what will be the scoring system we should follow in the emergency surgeries? Is there any scoring system?
Okay, the emergency surgeries, the higher the frailty scores or the advanced age, are the special considerations in where we have always we predict higher chances of major cardiac events perioperatively. So by keeping the nature of the emergency surgery, we can't further wait or delay them for advanced fancy testings. So we have to carry the best available on ground reality, the facilities we have, the plan we have, and the expertise we have. So there is none of the scoring system is devised for such emergency surgeries, rather than just to get as early as possible, make your patient hemodynamically stable, keep their heart rate normal, uh, keep their blood pressures within the normal, do a regular monitoring, and always do your clinical judgment, rather than based on these fancy scenarios or these fancy risk classification tools. Always rely on your clinical judgment.
Very true, sir. Sir, there is another question. For which patient we have to arrange an ICU bed in advance for these type of patients?
Definitely is a tricky question based on the setups, based on the patient history and examination and the type of the surgery, and definitely the expertise and facilities available in the institutes. So there is no rule of thumb for any patient that you should, before doing the surgery, you get a bed in the ICU, other than the specialty surgeries like the cardiac surgeries, the thoracic surgeries. Rest all the surgeries carries definitely chances that patient end up in the ICUs, but you never predict other than the simple things that is based on the preoperative settings, on the basis of the lab testing. If a patient who is unprone hypertension, or a patient who is presenting for any emergency surgeries having a BP of systolic more than 180, so you should keep ICU bed for him.
Agreed, sir. Sir, there is one question from Dr. Ruina. Dr. Ruina, will you please comprehend the question? I didn't get your question. Like, after doing high-risk case under general anesthesia, for how much time anesthetist is responsible after shifting the patient? Dr. Ruina, if you will you please elaborate your question, if possible?
I mean, when we do a high-risk case and we shift the patient to the recovery and then from the recovery to the ward, I'm asking for the duration, for how much time anesthesiologist is responsible for the patient. Hello?
Definitely. Yeah, please, sir.
Yeah, sir, will you please answer her question, sir?
Sure. Dr. Reader, definitely the anesthesiologist is responsible for the patient in the perioperative period, and there is no clear markings that up to 1 hour, up to 2 hour, up to 3 hour, we are responsible. But again, all things are just, it is a multidisciplinary teamwork involvement of the surgeon, the anesthetist, the intensivist. And as you forward your patient to intensive care unit, so further, after giving a thorough feedback, the thorough review of the patient and any peri-operative events notes to the intensive care unit, then you are free from further monitoring or any evaluations. So it is their
Right.
work to.
Okay. Okay. Thank you. Thank you.
Sir, there is one question. What would be the dose of antihypertensive? Should we reduce or continue the same?
Okay, this is again a bit tricky question. The dose adjustments that is usually a patient having in a pre-operative setting, we should carry the same doses, but definitely in the case of ARBIs or other who the drugs have higher chances of hypotension intraoperatively, so we should either quit their dose on the day of surgery or restart after 24 hours.
Okay, thank you, sir. There is a comment from Dr. Dilip in response to Dr. Reena that we have considered 24 hours. Basically, it's been considered post-operatively to evaluate the anesthesia risk. I think this is what she was asking.
Dilip is very right. But as
Yes.
Dr. Reena mentioned, the ICU, so once the patient is landed in the ICU, then it's their job. If patient is not forwarded or landed to ICU, then definitely up to 24 hours anesthetic is responsible.
Yeah, agreed, sir. Any other questions or comments? Yes.
Me,
Yes,
Dr.
please.
Sadia. I want to ask, have you ever experienced any of the MACE in your, any of you, or Dr. Sheharyar specifically, that have you ever experienced this MACE in your setting, and how did you manage this? Because I am working in a cardiac setup, and we most of the time we see it on the monitors, ECGs, the depressed STs, and sometimes the patient is there with the chest pain. So we rush them to the bypass, and that's we just manage the pre-bypass period. But how do you manage these kind of patients in the setting where we are very limited with limited resources, and also obviously the general setups don't have the bypass machines? We start them GTN right away, and then we try to manage the pressures with other inotropes also. So, sir, what you do?
Dr. Sadia, definitely it's a very basic question and basic concerns of anesthetists because if we see our academic books, so there are always two categories. One is the cardiac evaluation for the non-cardiac surgery, and then other is the cardiac evaluation for the cardiac surgeries. So whenever you are practicing the cardiac setups, so then you are the king because you have each and every facilities, and your patient and risk stratifications are already categorized, and you know the each and every planning and the medications, the skills, the teamwork, the management, everything is in your control. But in the general setups, the non-cardiac setups, the actual dilemma is over there. When you are not prepared, when you have not preoperatively seen your patient, when you have not stratified the risk of your patients, you did not know the histories and the medications and the prior events of your patients. So once you have jump into the war without having the emulation and the basic informations, then there is a nightmare. But the key is each and every time get the proper history, pre-operative settings, and where applicable, do the lab testings to avoid these MACE and every predictors of mortality.
Thank you, Dr. Sheharyar. Any questions or any comments from the participants? So I would like to thank Dr. Sheharyar for your time and for delivering an excellent lecture. And it's a very important topic. And also thanks all the participants for joining us online here. We're looking forward for your active participation throughout this lecture series in the future as well. So please fill out the feedback form in order to get your e-certificate. So feedback form link will be shared in the chat box. Dr. Sadia, will you please share? Thank you so much. Thank you, Dr. Sadia.
I
Thank
have
you all.
filled the
Thank you, Dr.
feedback
Sadia.
form.
Yes.
Thank you, Dr. Sheharyar, for really informative talk. And thank you, everyone, for joining with us.
Thank you.
Thank you. Allah Hafiz.
Allah Hafiz.
Dr. Saad, we have time. There's one more question, and if Dr. Sheharyar is with us, we can take that also.
Yes.
Yes, Dr. Sheharyar is online.
Ji.
Yes, Dr. Sadia, will you please share the question?
Okay. The question is from Dr. Naveed, and he's asking if the patient having 9 stents previously, what is the risk for spinal or general anesthesia, like doing inguinal hernia surgery?
Is it possible a patient is having 9 stents and still having a complaint of inguinal hernia surgery?
I guess
I
that's
don't think
not
so.
possible.
I don't think so.
We don't have
I
that
don't
much
think so.
arteries to stent. And obviously, but if the patient is having multiple stents, 2 or 3, then again, you can weigh him according to the scoring, risk scorings, and that Dr. Sheharyar has already shared. And then you can decide.
Dr. Sadia, one thing is important, that is even in the exam, the examiners would like to know whatever is your plan for the patient, either spinal, either general surgery, you should be master of that. That is the prime important. If I am master of patient monitoring and keeping them in hemodynamic status stable over the spinal surgeries, so I will proceed with the spinal. If I am confident enough that I will keep my patient in the GA and will keep everything in the control limits, so I should go with the GA. So none is the rule of thumb that spinal is superior than GA, GA is superior than spinal. It is the patient, it is the scenario, the disease process, the surgical interventions based on the surgery. So definitely always there is a plan tailored for each and every condition and patient, not there is a general rule.
Yes, very true, sir. So it depends upon the condition of the patient and the overall what are the facilities you have available there at that time.
Definitely.
Yes. So, Dr. Sajid, can we wrap up? I think there is no other question in the chat box as well.
Sure, I have shared the feedback form, and you all can kindly fill that form to get your certificate. Thank you,
Okay.
Dr. Sheharyar. So nice of you.
Thank you so much, sir.
Thank you. Thank you.
Thank you. Bye.